All right, so the last discussion this morning is about Graves' ophthalmopathy, Graves' eye disease. And as you've already kind of figured out, we have one or two people we've selected from each discipline. And Bill actually had some expertise prior from training in the UK. And as a legacy, his dad is also an ophthalmologist at CHOP. So he has a real foundation and footing at CHOP and has been a wonderful addition for our team. So all of our patients that have eye disease, Dr. Katowitz will see initially, and then I'm not sure what the percentage is. He'll probably let you guys know how many patients eventually need some type of surgical intervention. I think it's less than the patients that just need follow-up. But the follow-up is care that I'm not capable of providing. All of our expertise in Graves' ophthalmopathy is Dr. Katowitz, is not mine. I can identify it. He's better at taking care of it and deciding if and when something has to be done. So he is our only ophthalmologist. We have a neuro-ophthalmologist, Dr. Liu, as well. So between Dr. Liu and Dr. Katowitz, our patients, the ones that need care, are referred to them. So, Dr. Katowitz.
Thank you so much. And thank you, Dr. Bauer and Dr. Adzik, for inviting me to speak today. It's an honor, and I'm very excited to talk to you about eye disease. Can everyone hear me okay? Great. So I have no financial interest in any of the materials I'm presenting today. So who provides eye care? The primary care doctor in many cases. Someone says they have dry eyes. Typically, a primary care doctor may say, well, let's try artificial tears. Sometimes it's even a nurse practitioner in a practice or within a pediatrician's office. And then there are eye practitioners. And now an eye practitioner could be an optometrist, someone who went to something called optometry school. Sometimes even the optician, the person that dispenses glasses, will offer some eye care. And then finally, a person who is a medical doctor who is an ophthalmologist. And that's an eye doctor who completed a 4-year ophthalmology residency. They're board certified in the field of ophthalmology, which is spelled kind of oddly. And this is a person who has hospital privileges to perform eye surgery as well as surgery around the eye. And they do prescribe medications. Now, there are different kinds of ophthalmologists, and this is where it gets confusing. There are general ophthalmologists, and they sometimes see kids and adults. There are cornea specialists that will often address dry eye disease as well as other problems relating to the window of the eye. And then also very relevant to us here are pediatric ophthalmologists, who we have a very large practice here at Children's Hospital of Philadelphia. And those are people that see children and treat most diseases. And then within ophthalmology is this subset of eye doctors called oculoplastic surgeons, of which I am, and have had additional training in essentially plastic surgery around the eye. So I'm an eye doctor who did additional fellowship training and had fellowship training in both pediatric ophthalmology and this field of oculoplastics. And I did train here at Children's Hospital of Philadelphia, University of Pennsylvania, and then I spent a year actually in London where I saw a lot of patients with thyroid eye disease. When I speak with pediatricians and explain what it is oculoplastic surgeons do, I say there are 4 T's: tearing, tumors, trauma, and ptosis, which is actually spelled with a P, but it sounds like a T, so it works. So today I'll be speaking on the subject of thyroid eye disease and discussing the symptoms and then finishing up with treatments. And I know we're going to have questions at the end, but if I'm going too quickly or if I've explained something and I haven't explained it very well, please interrupt me and say, can you just clarify this? Because I'd like to just get these points across. So I realize I've left some things off this list that Dr. Bauer and Adzik presented because it's quite a large team. But I think it's just important, and I think you're hearing from today, that you are not alone in this process. And we are here as a service, as a center, to help you with many different supportive figures. So it was an Irish physician in 1835 who recognized that there was an association with an enlarged thyroid gland and bulging eyes, and this was Dr. James Graves. And this is a patient I treated who is in her teens, who has many of the classic symptoms of thyroid eye disease. In fact, her symptoms in some ways represent more of what we see in adults, but I thought this was a good person to start with because obviously you can see she has what you might see as very prominent eyes, or what we call eye bulging, and the medical term is proptosis or even exophthalmos. So you can see here her eyes are prominent or bulging. And it was an endocrinologist by the name of Rundle who in 1945 published a series where he noted that the bulging of eyes associated with hyperthyroidism occurred over a period of time got worse and then actually would get better, but never would resolve to what it was like before it all began for that patient. I was at a international meeting in LA about 10 years ago where a lot of the world leaders in thyroid eye disease, endocrinologists and surgeons met, and we tried to come up with a consensus of what we would call this syndrome, meaning person who has some form of thyroid dysfunction and eye symptoms, and we couldn't agree. Many of us like the term thyroid eye disease, but a group of Europeans actually have the term Graves' ophthalmopathy in their name, so we never really found an agreement. Some people like thyroid-associated orbitopathy because a small percentage of patients, not relevant today here, actually have hypothyroidism and present with eye disease, and some even have no symptoms, no thyroid dysfunction at all, but have the same type of symptoms and even on pathology look similar. So I'm going to use the term thyroid eye disease, but in the literature and out in the public, you may see a huge different a wide range of terms. So thyroid eye disease, and you'll see TED as a short term, so I don't have to keep saying it. So what can happen to your eyes if you have thyroid eye disease? Well, going back to our patient here who had this presentation in what we would call active thyroid eye disease, you can see that one of the most common things we see in thyroid eye disease, and that is lid retraction. Your eyes look, they're too high. It's almost like you have a surprised look. And this occurs oftentimes because there's scarring and inflammation within the muscles that lift the eyelid, both the lower and upper lid. And then you can see, obviously we talked about this already, the bulging eyes, so the eyes appearing more prominent. If you just sit in the audience and you do this for 3 seconds, you're going to want to blink because that actually leads to your eye feeling very dry. And this is unfortunately what some people really live with on a daily basis when their eyes are more prominent or they're proptotic. And that, in addition, leads to tearing because your cornea has a nerve in it that says, wait a minute, I'm drying out, I need to wet my eye, and that kicks in a gland here that then secretes a lot more water. And so people with dry eye actually tear. And we'll get to that later on. And then less commonly in children, much, much less commonly in children, is the eyes are not aligned. So typically we see our eyes are together. But sometimes patients with thyroid eye disease, because of the size of their muscles, the eyes are no longer aligned. One eye may be turned in, maybe turned out, maybe up, maybe down. And because of all this exposure, the lining of your eye or conjunctiva gets very red, so you have eye redness. They can get swollen, and really, really less commonly in children is some form of vision loss. Although I will say that dry eye typically will knock your vision down by 1 line. So people with exposure and dryness and even tearing typically have less sharp vision than the average person. So getting back to this curve, Rundle's curve, there is what we would call an active phase of eye disease and then a static phase. And this active phase can last anywhere from 6 months to 2 years typically. And then a static phase that typically lasts for a lifetime, although there are some things that can make the static phase worse, and I'll get to that in just a moment. So getting to why this happened, this is where I get overwhelmed because I'm an ophthalmologist and not an immunologist. But when I try to explain it to people, I just say this is an autoimmune disease. But when I show this slide, which is from a typical paper, you'll see that we think we're onto something, but there is no way we know the thing that causes this. It's really multifactorial. A colleague of mine has simplified it to recognize that there are some things on the surface of the eye, muscles and fat, that perhaps are related to the thyroid gland. But I really like to explain it this way. Your body is a factory. The factory makes immune cells that make antibodies that recognize something on your thyroid gland. And as luck would have it, in this case, bad luck, those similar surface markers are also on the muscles and fat around your eye, therefore giving you a similar type of enlargement. And in this case, it behaves differently because it's your eyes, but as your thyroid gland will enlarge, your eyes, the eyeball doesn't enlarge, but the eye looks like it's bigger because it's being pushed out. So what actually happens? Well, this is a CAT scan. This is an X-ray that's done in serial slices, and then the computer puts it back together. That's what computer tomography is, so a CAT scan. And this shows that the eyes, well, you may not appreciate this, but the eyes are being pushed outward because that black space around, let's see if this pointer works. So this is your optic nerve, and these are your eye muscles, and these are your eyeballs. But this black space here is actually larger because it's essentially swollen. There's more water and there's more extracellular tissue, and later on there's scarring. So that pushes the eye out. Sometimes, if we go back for a second, see how small this muscle is? Now look how big this muscle is. And that's just giant. And your eye sits in a room called your orbit, which is surrounded by bones. And as those muscles enlarge, the eye has nowhere to go but out. So this is a person with very large eye muscles. And this is something we see less typically in children, but it can happen, especially in adolescents. So some people, and I'd say this is more typical for many kids who are older in their teen years, have more of a balanced appearance where some of the fat is enlarged and some of the muscle is enlarged. And this becomes relevant later on when we ever talk about surgery, if it ever comes to that. So through my years of training and in treating adults, because I also see adults, and I feel like a patient with thyroid eye disease, especially a child, is my patient for life, because this is not necessarily going to go away. It'll get better, but I inherit them as adults, and I see the adults at the Children's Hospital of Philadelphia. I like this slide because it really shows this wide spectrum of presentation that people have in thyroid eye disease. Some people look, essentially, you would almost say that person looks normal. Other people, you would say, okay, this person has very red eyes, or this person looks like she has a normal eye, but one eye is actually sticking out. And I put this picture in because this is a pediatric patient, but just to show you the difference. The good news is that eye disease in pediatric patients is not as severe as in adults, and I'll get to that. And these are some of the many patients I've treated over the years at the Children's Hospital of Philadelphia with thyroid eye disease, and also you can see a varied presentation. This teenager is much more like the adult pictures I showed you. You may recognize, but it may be hard to tell, this is the only boy in the whole series because there really is a higher prevalence of this presentation in female patients. But you can also see some patients don't look as severe, but if they showed you pictures of them previously, they say, no, my appearance has changed. Whereas other people have one more eye that's prevalent, that's sticking out versus the other. So how does an eye doctor help in terms of treating patients with thyroid eye disease and hyperthyroidism? Well, I will say usually we don't diagnose the hyperthyroidism. I've done it a few times, but usually I will see a person who already has a known diagnosis. It's bulging eyes or proptosis. The most common cause in kids is usually actually an infection of the eye. But when we see a bulging eye, we usually get imaging and are able to diagnose something that is related to thyroid function, and then we send them to a pediatrician and then an endocrinologist for a true diagnosis of hyperthyroidism. We're really there to treat symptoms in this active phase and then help restore appearance in what we call the static phase. And that usually does not involve surgery, but at the end I'll discuss that. So this is a young person we've seen. We put some yellow fluorescein dye in her eye. That's why this is green there, so that we can see if she has any dryness and staining on her cornea. When you have eye dryness, the surface of your cornea looks, I described to parents, it's like the surface of the moon. There are these little craterations. I say to kids, it's like taking a chocolate chip cookie and wiping the chocolate chips off. There are these little spaces, and that's actually causes a certain amount of discomfort. And people, when they have this, they actually sleep often with their eyes open at night, and I'll explain that in a second. So you can see this patient has some prominence to the eyes, and the parents showed me on their cell phone, they said, you know, this is the way my daughter looked before this all began. So you can definitely see a difference between before and after the beginning of onset of disease. So the most common eye symptoms that we see in pediatric patients is eyelid retraction or lid lag. The lids are too high, dry eye and tearing, proptosis, and crossing really is much less common. And severe vision loss, as in blinding vision loss, has never been reported in kids, whereas in adults you'll see numbers anywhere from 3 to 6%, not necessarily blinding, but severe vision loss. This is a large study that came out of Boston that looked at 163 children and found that when they split up the difference between kids that were pre-pubertal and post-pubertal, that about a third of them had proptosis, and the most common being still lid lag, and about half of kids had some form of eye complaint or presentation. And when we looked at, when they looked at their patients based on the eye alignment, they also had a very small number of kids that, well, it's not small in the series per se, but out of 163, this is the patients that were referred to the ophthalmologist. And so their point And we found a similar thing in our study, is that out of a large group of patients, very few are actually referred to an eye doctor because most don't actually have severe problems. When we looked at our practice, this was published back in 2008, we followed 152 patients. Only 27 of those were referred to us, and we found about a third of the patients we followed had proptosis and lid retractions, and there were no cases of eye misalignment. And 2 of those patients went on to have eye surgery. And I would say that's probably the same for where I am now in my practice. It's about 10% of patients that might actually have eye surgery in their life. So what happens when you have eyelid retraction? Well, as I said, if you hold your eyelid open, it becomes incredibly annoying just for even 2-3 seconds. It leads to this inability to fully close your eyes. And patients can sleep with their eyes partly open, and this leads to dry eyes, and it also leads to tearing. So here's a young person with prominent eyes, and you can see when she closes her eyes, she has this incomplete closure. And about 80% of us have this thing called the Bell's phenomenon. So as we sleep, as we close our eyes rotate upward, and that can occur during sleep as well. But some people don't. So if a person doesn't have this Bell phenomenon, they tend to have worse dry eye symptoms when they have that inability to close their eyes. And if we were to look at the balance of being too dry or too wet, you would much rather have watery eye than a dry eye. Because a dry eye, every moment, you're just aware your eyes are dry, and you're pretty much wetting your eyes every hour. Whereas a wet eye is just more of an annoyance. You're just wiping your face. So there is a syndrome of dry eye syndrome where you're not making enough tears. But what can happen to some people is because of the dryness, they can develop a lot of inflammation in their eyelid, and it can give them more of a dry eye. And as I said, this often leads to tearing. Last night I was thinking, maybe I should think about medications, because I gave a similar presentation at a thyroid cancer survivors meeting last year, where we focused a lot on the symptoms of medications, where they're much more associated with eye disease in the setting of thyroid cancer. But I looked to see if methimazole, which is obviously this medication many people have taken, if that leads to dry eye. And this is not scientific reviewed. I don't know if eHealthMe is a legitimate website. But they said that out of 1,478 people that queried, only 4 people said they had dry eye associated with this medication. So I think it's safe to say that if you have dry eye and you have hyperthyroidism, then it's probably more associated with some kind of eye disease rather than the medication you're on. So getting back to our patient that we initially saw, this is an adult with a similar thing, just showing you how severe eye retraction can be. And just to have a brief review of the anatomy, your eyelid and the eyeball itself makes tears. And then you have this big gland here called your thyroid gland, and that's the gland that kicks in when you win the lottery or if you're cutting onions. But typically, that gland is not producing a lot of tears. But in a person with dry eye, it might start kicking in more because your eye is saying, I'm dry, and then your lacrimal gland is releasing more liquid, and then what happens is you start to tear. The other thing that can happen is your tears is this critical thing that provides nourishment to your cornea and improves lubrication. It also has antibodies in them, so tears can actually become very annoying to your eye if they stick around too long. And the other thing that can happen, this is more, you didn't think you were going to hear about tears today, right? It's so much detail about tears. But it's this little sandwich of different layers. There's a little fatty layer on the surface, and then there's a watery layer, and then there's a little mucinous layer. And as you get inflammation in your eyelid, your tears start to evaporate. So you make tears, but they're actually not good functional tears over time if you have a lot of problems with exposure. So what do? We actually do what you wouldn't think we'd do, and this is just to show you the lining of the eyelid, how you can get inflammation associated with having dry eye. So the treatment option actually is to add more tears. Why? Because you're adding a healthier substance that's going to stay on the surface of your eye, that's going to fool your cornea into thinking you're now properly lubricated so that you don't tear more. So this is just a showing you some of the armamentarium of tears that you'll see in a CVS or Rite Aid or local pharmacy. And the one thing that I always stress to patients and parents is that if you look at these boxes, they're all small. They're all very small. Because a big bottle to be able to sit on a shelf or sit in your medicine cabinet requires preservatives. And preservatives are very hyperallergenic. So if you I know the saline solutions for for contact lenses are big, but a lot of these have a substance called methylcellulose. It's a substance that actually doesn't evaporate so quickly. It lines the surface of your eye and will stick around longer. Those have to be very small because the bigger ones require a lot of preservatives, and people will develop allergies, a lot of itching and redness from the tears you're using. So in general, if you see a big bottle, you may want to avoid it. The problem with these small things is they can be expensive. So we try to recommend them, and people typically find one that works. It's a lot of trial and error, and they come in a range of mild to severe. If you look here at this medicine cabinet, you'll see some of them are color-coded. This is a product genteel. We don't sell or promote any of them. In fact, I find some people like one or the other, and I just recommend a little bit of trial and error, and we have samples in our office that we'll give to patients. But I typically tell people to start with the moderate ones and then to go up to severe if they feel like they need it. Or sometimes they'll use a severe at bedtime because it's thicker. So once again, big bottles equals risk of allergy. The other option, if you feel like tears aren't working, or if you say, I've been using tears, is there anything else I can do? And you really feel like the artificial tears are helping, is there's actually a plug we can put where your tears drain. So you have these two little pipes in your eyelid, and when you close your eyes, you pump the excess tears that haven't evaporated into your nose. And so you can put this little plug to cover either the lower or the upper or both drains in your eyelid to help your tears stick around longer. And that sometimes is a wonderful treatment. It's a very common dry eye treatment. And we can insert these even in really young kids in the office. It doesn't require going to an operating room. And it's usually not painful at all. It's just a little scary and annoying. This is just showing you, this actually is a special kind of a punctal plug. It's rather larger than the typical one, but I like this picture because it's easy to see that plug there. And that's where they typically be. And usually don't feel them. People usually don't feel them, and they come in different sizes. So sometimes we start with smaller ones, and if they fall out, we'll go to bigger ones. And we avoid trying to put in really big ones because initially some people really can feel them. So is this clear? Do you have any questions initially about dry eyes? It's kind of a surprising subject in the setting of thyroid eye disease. But anecdotally, I will tell you that people that I've treated with bulging eyes, especially the ones that we've had decompression, some of the kids and certainly adults have said to me is, I feel better. I don't feel dry anymore. And so I feel like it's one of the things you should be aware of, especially having your armamentarium. And a lot of people, as we become richer in years, acquire dry eye syndromes. And this is a totally separate subject, but they're used to the use of artificial tears. So eye bulging can be very disturbing, and this is where we're going to finish up and talk about the treatment of proptosis and possibly even surgery. And it's, as I mentioned, due to swollen and then scarred orbital fat and muscles. And it usually will get worse in the setting of your thyroid dysfunction, but it never resolves, but it usually gets a little bit better, but never, as I said, goes back to the way it was before everything began. There are a few factors that may make things worse for you. So if you have poorly controlled thyroid function and you're actively inflamed, in other words, we feel like you're in this active phase of changing of your eyes, then typically your eyes won't improve. So it's important to try to get on top of your thyroid function. This is obviously where the endocrinologists and thyroid surgeons are critical. Now, smoking has really been shown to be one of these exacerbating factors that can make your eyes worse and that can reactivate your eye disease. And smoking, obviously, we don't necessarily think about it in kids. The problem is that kids are around smoking. And so the European community that have done 2 large studies have actually determined that secondhand smoke is a significant risk factor for prolongation or reactivation of eye disease. And finally, if you have active eye disease and you're going to be treated with radioactive iodine, sometimes I think it is helpful to have a treatment of an oral steroid right before and then after on a taper after you have your radioactive iodine to help decrease an exacerbation, meaning a worsening of the eye disease. So when I meet children and adults with proptosis in the setting of thyroid eye disease, I really want to know, are you bothered by how you feel? And I'm really careful in asking, but I do ask, are you bothered by how you look? And I guess the real question is should we even be talking about this? Should we be sensitizing ourselves to whether or not having eyes that change is really bad at all? And then finally, the subject of surgical rehabilitation really is an option. It's not a requirement, especially in the fact that there is no vision loss. And I just want to show, because I like showing these pictures of some people who have very prominent eyes, and people we've embraced as beautiful in our society, such as the actress Bette Davis, or maybe, I don't remember her name, she's from Modern Family. Do people recognize this actress? She has very prominent eyes. And then this is a model actress some people may recognize, Mila Kunis. And then there's some very famous people with thyroid eye disease. This gentleman probably is famous because of his thyroid eye disease. A very famous actor, comedian, Marty Feldman. Barbara Bush had thyroid eye disease. Do people know that? It was kind of hard to miss. And then, obviously, many people might be aware that Oprah Winfrey had thyroid eye disease. And I found it very interesting that in her Time magazine story about her, they chose to give a great portrait of her showing her thyroid eye disease. I mean, these are very prominent eyes. And you can see later on in life, I'm assuming she had a thyroid decompression surgery because she really does look quite different. And then I love this picture of Susan Sarandon because she's smoking. And it's clearly that this is the one thing she shouldn't be doing. But she's also someone who's had thyroid eye disease and has definitely had surgery in the past. This is a patient I treated who was an adult, and she told me she's bothered by her appearance. And you can see she has this flare for eyelid, and sometimes people have what we call a lateral flare to their eyelids, and that's often a scene in thyroid eye disease. And this was her before this all began. So you can see how there was really a change in her appearance. And this was just as she became hyperthyroid. You can even see her right eye is more prominent. And then it just progressed to the first picture I showed you. Here's a young gentleman I showed you initially, and you may see this gentleman looks normal to me, but hey, when he was younger, when he was a teenager, this is how he looked. So he developed thyroid eye disease in his teens and came and sought us out for decompression surgery as an adult. And you can see really how prominent his eyes are relative to the bones around his face. Another adult with eyes that you'd say, oh, is she really have prominent eyes? But when you see how she appeared when she was a bit younger in her early 20s, you can see the difference. And then getting back to the patient I showed you before, her appearance, and then her appearance before her hyperthyroidism kicked in, and then her eyes began to bulge. The European group of Graves' orbitopathy actually has a quality of life questionnaire that they often give their patients, asking, are you seriously limited, a little limited, or not limited at all in your activities of daily living, driving, moving around, reading, watching TV. Watching TV, by the way, is the worst because you're concentrating and you forget to blink. So one of the most common symptoms is a person is tearing more when they're working or watching TV, or when they go outside and the wind is blowing and their eyes become actually drier because their tears are being blown off their eye. And this questionnaire goes on to ask more questions in general. Do you feel that your appearance has changed? Do you feel that you are stared at in the streets? Do you feel that people react unpleasantly? So on and so forth. And once again, I think this is a very tricky subject, and I always prefer to have a family or a patient come to me and say, I'm really bothered by this, rather than to sensitize them to it. I had one patient who was in her teenage years, and her friends used to call her Garfield, which I thought was really cruel. And she was really bothered by this. Garfield, is the cat that has really prominent eyes. And so she sought me out because she really was unhappy with her appearance, and she really felt that she was being teased. So one of the things we can do is a surgical decompression. And this is a treatment to help the eye sink backward into the orbit. And it is a treatment for proptosis and involves removal of bone and or fat around the eye. And so getting back to a CAT scan, and once again you see the two eyes and you can see these muscles have thickened. What our goal is to make more room so that this tissue can actually sit back further. And so what we do is we make big windows in the bone. I mean, these are very large. You can't feel them, you certainly can't see them. And what they do is it allows the tissue to essentially prolapse or pooch out through these windows and the eyes to sink backwards. That patient that I showed you, that had the pictures of when she was younger, you can see her before and after surgery. Now you'd say, is there any difference? Well, actually, when you look at her, there's a huge difference. It's maybe a little over half, maybe 3/4 of an inch. That's about 8 millimeters of her eye being more sunken back and moving back up to here. I think it's important to see the eyelids often remain very high. And so patients often need another procedure to lower the eyelids. And we usually don't do them at the same time because sometimes the lids come down and we don't want to do an unnecessary procedure and make the lids too low. That's what happened here in this patient. This was a pediatric patient whose orbits we helped open. And you can see we lowered her eyelids and we lowered it a little bit too much. We try to avoid doing it, but it sometimes does happen, and so we wound up raising her eyelid here. But you can see all this white in her eyes here that you can see? You no longer see this, so she has much better closure of her eyes, and her eyes are more sunken back inward. Since we've been doing the surgery, there have been some advances in our surgical technique. So a device we share with the neurosurgeons is this bone aspirator that allows us to no longer make a little skin incision. We do this, and we've found that our patients have had a faster recovery, and it's been less invasive. And so I don't promote this in terms of the maker, but it's called the Sonopet. It's slower, but it's less invasive. There's less bleeding. And once again, what we're able to do is push the eye aside and get to these bones, specifically here and here, to make more room so the eyes can sink backwards. And here's another pediatric patient we had operated on who has very prominent eyes. She's smiling here, so it almost makes her look a little bit better. But I figured I'd use it. And she's very happy with the surgery. And you can see before and after, less white being shown. She had about 6 millimeters reduction. Another patient who has prominent eyes, and this is her after surgery. You can see how you see more lid here. She's more sunken in. And she was one person in particular who said, my eyes just feel a lot better. And you can see before and afters. But she actually went on to need lid lowering. So we actually just recently lowered her eyelids in the office. Another patient who felt that her left eye was more prominent. It was really bothering her, and she wanted it evened. And we went ahead and did that, and you can see the appearance is a little more symmetric, and it's a little more symmetric post-operatively here. So the alternative to removing bone is we can actually remove some fat if a person has their eyes bulging, mainly due to the fat compartment. And this is less of a decompression. So if a person has a lot of high prominence, we sometimes will remove fat and bone. But I just wanted to show you one particular patient who we did this surgery on. And this is a young patient who was unhappy with her eye appearance. And you can see her eye bulging here with proptosis. One thing we don't typically talk much about in kids, once again, is her motility. So you can see she can look left, up and down just fine. She's not restricted. And this is her before surgery, and this is her CAT scan just showing she has these very enlarged compartments, mainly due to fat enlargement. And this is the fat we removed from the 4 quadrants, and this is her after surgery. So this is the appearance before and then 1 year after surgery. And she had an eyelid tightening procedure at the same time, which actually helped her close her eyes. So in terms of timing of surgery, patients need to be at least 9, but ideally into their mid to late teens for multiple reasons. One is their head is growing. And so we would never operate on a child under the age of 9 unless they had vision loss. And I've never heard of that happening, and I don't anticipate it would ever be an issue. They really must be in the static phase of thyroid eye disease. And we do check these TSI levels. And I ideally want a patient who is at least 1 to 2 years out of their active phase of inflammation, because the risk of surgery, of performing surgery in a patient who is actively inflamed around their eyes, is when you do the surgery, you can make their eye disease worse. So, and we typically want a patient to be well out from their thyroid active disease. We usually will get a CAT scan to evaluate their eye muscles, and I usually don't get a CAT scan, actually. So it's only in patients where it's unclear what the diagnosis is, which is really rare in Graves' disease, or in patients who we are discussing surgery, who we go on to then give a CAT scan to. I always tell parents and families and patients, ideally you do this in the summer or during a big break, because it's 1 to 2 weeks of recovery. You're pretty swollen, although I'd say we're doing better in terms of how people feel. We usually ask people to spend at least 1 night in the hospital, and I'd say their average stay is about 1.5 days, because sometimes people are in a little bit of pain afterwards. Just to summarize, that orbitopathy, or the problems we see in the eyes, are typically much, much less severe than in adults. And an eye doctor can be helpful in managing these symptoms related to thyroid dysfunction. And pediatric patients with bulging eyes really can be successfully rehabilitated with surgery, but this is purely optional. And we would perform bony and fat decompressions in this setting. And thank you once again for your attention today.